Dr. Aziz, you will take care about our speakers. Share, Abdullah, please, the MEOM.
السلام عليكم.
السلام ورحمة الله. دكتور
Wah,
محمد.
syukran.
Abdullah, can you share, please, the MEOM Academy, please, the name of our speaker panelist? Okay. Assalamu alaikum wa rahmatullah. Good evening, dear colleagues and friends. Welcome to MEOM webinar meetings, a continuous education for our colleagues and participation of many of our speakers from different parts of the world. In addition to, we are having today really an eminent panelist and expert, and all of them part of the MEOM Academy board. And actually, also we have a special guest from Pakistan, Dr. Homa. She is also our guest today out of our board, but she is board also with us anyway. So our expert, Abdullah, can you share the photos of our expert? Go down, please. Anyway, I know all of them, most of them, so I will give the names. We have Dr. Muhammad Awadallah. He is a VR surgeon in Cairo University, and he is the head of scientific committees of MEOM Academy. We are having, not this one, Abdullah, not this one. Anyway, we are having Dr. Hiba Mutwalli, and Dr. Hiba Mutwalli, she is a pediatric ophthalmologist in Egypt, Cairo. in نسيت اسمه ايه يا دكتورة بالانجليزي تبعكم تسموه ايه؟
Memorial Institute Kids Eye
Memorial Institute in Egypt, yeah. And she is a well-known figure also worldwide, and we are happy that she is with us today. The other one will be another name, the Abdullah Sura type. Dr. Sefda, also she is a VR surgeon from Azerbaijan, and she is part of MEOM Academy in organizing committee. We are having also Dr. Huma, as I mentioned earlier. She is a VR consultant, and she is from Pakistan, and she is the General Secretary of Pakistan Veterinary Society. We are having also Dr. Muhammad Atif, and he is a VR consultant in United Arab Emirates, Sharjah University Hospital, and he is also a dear colleague and friend. As you know, all of you, and Dr. Nazim Al-Hussein, he's a well-known, no need to talk about him. He is well-known VR consultant, and he is the General Secretary of MEOM Academy, dear friends and brothers. Dr. Barrel, I don't know if she joined us or not. She's a glaucoma consultant, and she is from India, from Chandigarh. And I think she is now General Secretary of Chandigarh in Ophthalmology Society. I will leave the introduction for the young ophthalmologist for Dr. Aziz. Please, Dr. Aziz. Unmute yourself.
Hi, I'm Dr. Aziz Jan Bashir, and I am the current young ophthalmologist chapter of the MEOM Society president. And we have five speakers today with us. Number one is Dr. Please correct me if I pronounce it wrong, Dr. Atanas? Atanas? Is
Bigo.
it?
Atanas Bigo.
Oh, Atanas Bugo. He's a consultant ophthalmologist from Germany and with special interest in anterior segment and glaucoma surgeries. He's the founder of Ophthalmology 24, and he is a member of the executive committee of European Society of Ophthalmologists. And we'll hear him discuss cases regarding glaucoma. The next is Dr. Gunbola Turbot. She's an ophthalmology resident from First Central Hospital of Mongolia, and she's an upcoming ophthalmologist and part of a very dynamic Mongolian Young Ophthalmologist Society. And then we have Dr. Kamal Tekin, who is an associate professor. Sorry?
That's right. Yeah.
Yeah, Kamal
Pronunciation
Tekin.
is- Yeah.
And he is an associate professor of ophthalmology at Ulu Kanlar Eye Training and Research Hospital, and he specializes in medical and surgical retina. Then we have Dr. Nilesh Kumar. He's the secretary of the Young Ophthalmologist Society of India, and he's a well-known person in the young ophthalmologist circles of India. He has won numerous national and international awards with a lot of peer-reviewed publications, and he is an innovator too, and with a patent pending, but he has introduced DIGS and DIGS Pro, and I think Dr. Muhammad Reda Dr. Muhammad Alamri, I think you would like to introduce Dr. Muhammad Reda.
Okay, Dr. Muhammad Rida, he is a, consultant ophthalmologist. I think, yeah, Muhammad, correct me if there is any mistake information. And he is working in Memorial Institute in Egypt.
Yeah, assistant lecturer.
Okay, assistant lecturer. Okay,
Yeah.
and which specialization you are looking?
In cornea, bro.
In cornea.
Yeah.
So I think by this we thank you, Dr. Aziz. Also, I forget, I'm sorry, Dr. Aziz, but you are well known. Dr. Aziz also is a VR surgeon, and he is president of MEOM Academy Young Ophthalmologists. So we will start now our presentation, and we will start with Dr. Atif, and he will give a talk about biosimilar new era of anti-VEGF. Dr. Atif, please. Dr. Atif, can you hear me?
Yes.
Yeah, okay, please.
Just 1 minute. Yes. Assalamu alaikum warahmatullahi wabarakatuh. Thank you, MEOM, for this opportunity. Today, I will just start with Revixa. Revixa is ranibizumab. It is FYB201. I think I'm having some issues with the, yeah. Now, what's important, and I think all of us are very well aware of anti-VEGF agents and their roles in diabetic retinopathy. The rationale of the therapy that anti-VEGF actually inhibits VEGF, which is vascular endothelial growth factors. Now, these are known to be increased in the retina and the vitreous in diabetic retinopathy. These increased VEGF levels actually are important mediators for the blood retinal barriers breakdown. What is ranibizumab? We do have multiple monoclonal antibodies in the industry. Now, ranibizumab is just a fragment and it has been designed for intraocular use. And it functions by inactivating all the isoforms of VEGF-A. What the VEGF-A does is it binds to the VEGF-R2 receptors, and that leads to endothelial cell proliferation and neovascularization, and also has vascular leakage. Ranibizumab approved from a long time, from 2011, and it was the European Medical Agency which actually approved it first. There was a difference of the dosing in Europe and in the United States. 0.5 in Europe, and in United States is 0.3 milligram. Coming to the efficacy, studies have shown that ranibizumab is as good as any other anti-VEGF agent for patients with a baseline best corrected visual acuity, letter score of 69 letters and above. Now, coming to a poorer baseline visual acuity, the results are almost the same at the end of 2 years. It is as good as aflibercept, but yes, what is shown is that the effect the effect is kind of slower. This is according to the protocol T. Now, why does that happen? It's a matter of debate. It's a matter of controversy. People could amount it to a lower molar dose, because in protocol T, during the study, basically the dose which was used was 0.3 and not 0.5 milligram. Coming to its safety, ranibizumab is very beneficial, and it is very safe in terms of systemic safety or cardiovascular events, or even as such intraocular, as safe for intraocular use. Now, Revixa, the indications, it's a biosimilar. The indications are as how the indications are for ranibizumab. So here you have age-related macular degeneration, the wet type. Then you do have for the diabetic macular edemas, proliferative diabetic retinopathies, macular edema secondary to vein occlusions, and then any other sort of choroidal neovascularization due to other reasons. Dosing, same as ranibizumab, 0.5 milligram, around 0.05 ml. Hepatic, renal adjustments, nothing has been mentioned on that. We don't need to have any further adjustments. There's no dose adjustments even for the elderly. Plenty of clinical trials, phase 3 evidence we have. Now in this, we have the different molecules, ranibizumab, we have aflibercept. Now the comparisons in different studies are with either with each other or with compared to laser, with a combination of laser, with deferred laser. So, and if you notice, there's also different dosing schedules, whether it could be monthly injections, then loading doses with PRN, or treat and extend. And if you come to even Vivid and Vista, done for aflibercept, 5 loading doses with bi-monthly injections. So after all these studies, after all these protocols, what has been noticed that at the end of 12 months, the visual acuity scores, regardless of the dosing or the anti-VEGF agent use, is the same. Almost, there's hardly any difference between them. Coming to the number of injections over a period of time, the number of injections required are lesser. Ranibizumab, when it comes to it does provide good visual acuity outcomes in patients even with poor baseline visions. Now, DRCR net has actually shown that in the protocol I. You can see there's almost 17 letters improvement over a period of time, up to 260 weeks, and even if with a deferred laser, with the prompt laser, it's much lesser. Protocol T. Now, this was the first head-on-head study between the 3 anti-VEGF drugs available at that time. So this was conducted by the National Eye Institute in the US. They had around 660 patients, and the visual acuity that was the baseline visual acuity at that point of time mentioned was around 20 by 32 and between 20 by 32 and 20 by 320. Now in these 660 patients, you had three different groups: aflibercept, 2 milligram, 1.25 milligrams of bevacizumab, and 0.3 and not 0.5 milligram intravitreal ranibizumab. So they had regular intervals of visit, and then at 24 weeks, a focal laser or grid laser would be done if the OCT thickness was more than 250 microns, or that if the edema was threatening the fovea, or if there was no improvement or in the OCT or the visual acuity from the two last consecutive injections. In second year, the visits were either 3 to 5 weeks, between 3 to 5 weeks, as long as the intravitreal injections were given. Otherwise, it was extended to around 4 to 16 weeks. Now, when you come to the visual acuity change in the first year, now this is cumulatively for all the participants, there was hardly much of a difference between the three drugs, with almost plus 13 visual letter gains in the aflibercept, and 11 letter gain in ranibizumab, and plus 9 in bevacizumab. Now, coming to patients who had visual acuity anywhere between 78 to 69 letters, in the very first year, there was hardly any difference between the three drugs. Now, in those who had visual acuity, which was lesser than 69 letters, there was quite a bit of a difference that was noticed in the first year. You can see that aflibercept was around plus 18, plus 14 in ranibizumab, and plus 11 in the bevacizumab group. But when they came across all the patients at the end of 2 years, there was hardly any difference between any of the drugs, whether that was cumulatively. And if you see between in patients who had good baseline visual acuity, all the three drugs did relatively well. In fact, in this slide, you would see the ranibizumab group being slightly higher than the aflibercept group. And at the end of 2 years, with poor visual acuity, baseline visual acuity less than 69 letters, you would find that the group they were almost the same, with 18 visual letters, 18 letters gain in the visual acuity in aflibercept, 16 in the ranibizumab, and 13 in the bevacizumab. Total number of injections, there was no difference in the first year or the 2 years. Hardly any difference. There was almost the same number of injections in the groups. Safety protocol T showed that all the three groups were safe. Here, there was only one thing to mention, that here in patients who had a prior coronary artery disease, that without any myocardial infarction, you see the percentage was shown a little to be high, on the higher side, around 34%. Now, this was because they already had the total number of patients with the pre-existing. I mean, these are patients with the pre-existing coronary artery disease. There were a higher number in there, basically, compared to the other groups. So now, what did the EURETINA guidelines say? Early intervention in diabetic macular edema was the best thing to do. Anti-VEGFs were the first line of treatment. It was way ahead of laser. Patients with visual acuity better than 69 letters, all three anti-VEGF agents were good. They were equal. And in patients with lesser than that, ranibizumab and aflibercept were comparable, but aflibercept is proposed as treatment to start based on outcomes from protocol T because of the 1-year results. Of course, as we mentioned, there were internal contradictions, but nevertheless, it was just that over a period of 2 years, you would see that they would have almost the same visual acuity gains. Now, the authors did recognize that the absence of difference after 2 years of treatment and overall position, all three anti-VEGF agents were comparable. Now, coming to biosimilars, just to let you know what is a biological medicine. Biological medical medicines are nothing, but they come from living organisms. These are living cells. They have been modified using biotechnology to produce some active substance of biological medicine. Now, you could see them. The examples of these are include hormones, growth hormone, insulin, growth hormones, and monoclonal antibodies. And these are used to treat several diseases. So here you go, insulin there, growth hormones, and monoclonal antibodies. So what is it basically? It is a medicine which is similar to existing biological medicine. This is called as a reference medicine. This biological medicine has already been proved in its efficacy. So what the biosimilar is, it is highly similar to a reference medicine already existing. There may be some minor differences which will exist. And these minor differences are basically because the active substances which are present in them are very large and complex. So even before this biosimilar medicines are approved, so they are rigorously tested for their efficacy, safety, and purity. So again, now in this about Revexa, now what has actually come out is from the Columbus trial. So ranibizumab, it was just a humanized marine anti-VEGF and a monoclonal antibody. It has a high binding affinity to the binding site of all VEGF-A isoforms. So FIB201, it's a candidate biosimilar, and it is produced again by E. coli by periplasmic expressions. These are the studies which have actually proved their efficacy, and this is the Columbus trial. The efficacy in terms of the visual acuity, the central retinal thickness, and the safety profile and immunogenicity. Study designs 477 patients over 48 weeks, comparing the reference drug with the biosimilar. When you see both the drugs, whether it was the reference or the biosimilar, both have done equally well. The visual acuity outcomes were very good, equal and very good. When it comes to drying effect, there was no significant difference between the two groups, in the percentage of the fluid-free retina, and the foveal center point and the foveal subfield retinal thickness. There was no difference in the measures in both the groups. Coming to immunogenicity, see, after the first injections, generally here what has happened, it has proved to be very safe.
Sir Muhammad, if you can manage to conclude fast, please.
Yeah. So then I'll push a little. So that's it. So when it comes to the safety profile, it has been proved to be very safe, and there are no safety concerns as such. It is approved again for the DME, PDR, neovascular AMD, CNV for other causes, and retinal vein occlusions. So ranibizumab is indispensable. Okay, so it has an experience of around 17 years, and when it comes to biosimilar, comparing to the reference drug, it is almost it's cost efficient because it's 20%, 28% safer. Guidelines, again, less than for 69 letters, ranibizumab and aflibercept. This is the EURETINA guidelines. And coming to the last part, it is approved by the SFDA, by the US FDA, EMA, and it's only by ranibizumab biosimilar that has FDA approval for interchangeability. This is something which is important, where there are two types of interchangeable, two types of things. One is a standard interchangeable a standard biosimilar and an interchangeable biosimilar. So a standard biosimilar is that where even once it has to be specified by the physician, and the pharmacist cannot change it. And an interchangeable biosimilar is such that even if the physician has prescribed, the pharmacist can automatically swap this drug swap the original reference to the biosimilar when it comes to cost effectiveness, and that for the ease of the patient. So that's why it's an interchangeable biosimilar, which is very, very important and very, very convenient. So all, as I said, phase 3 clinical trials it has proved to be very safe and efficient. So thank you.
Thank you very much, Dr. Muhammad, for this excellent presentation, and also it is very clear for every one of us. I think if there is any comment on any question from our panelists or Dr. Nadeem, Dr. Homa, I don't know if you start having this biosimilar in Pakistan or not. Also, Dr. Aziz, Dr. Hiba, Dr. Ahmad, any one of you, please.
I have one question for Dr. Muhammad. We knew now what's the difference between biosimilar and Lucentis itself. What is the difference? The differences, between biosimilars themselves. One biosimilar, how one biosimilar is different than the other.
I mean, see, because I think right now at this point of time we just
have many ranibizumab biosimilars, right?
Yeah, it's true. But at this point of time, I have encountered only Revixa as one of the biosimilars, and I do not know about the rest. I think even Aflibercept, for that matter, would be FYB 203. I don't think we have it launched here as yet. So
I think Dr. Muhammad Awdallah is talking about we are having ranibizumab itself, many companies. I think they are almost maybe similar.
In India, yeah, in India
but
we do
they
have
are having just their, different company than like when you are having, for suppose we are talking about drugs like acetazolamide. It have produced by many different companies. That means this company belong to each one, because now the patency already of ranibizumab, the original one, already finished. So they are able, a new company, to produce this one in this way. And biosimilar, usually it produced by bacterial or viral, that they are using the gene, so replicated and something like that, and it become well known. It's biosimilar now, and they tested, and there is many company now. There is a lot of ranibizumab, biosimilar available now in the market, but the one we are talking about is Revixa, and the most widely used until now. I feel the other one, they are not like that. Now there is around maybe 20 Aflibercept available, and they are, some of them 3 or 4 already approved, and maybe only one will. This is only the purity and how they are very, what I can say, they build it or make it in a proper way that almost similar to the original one, and give the same result, either the efficacy or the safety profile, and they are tested, and they are doing a study to get the approval. They are not like this, just a medicine. It is similar to ranibizumab, and that's it. No, it is similar by everything, but also it should be tested and giving an approval by the FDA or EMA.
I think in
Uh,
UAE, we still just have
Can
Revixa
I
similar. But I don't know if any.
can I
Yeah, Dr.
comment?
Nazim. Yes, Dr. Nazim.
Yeah, Dr. Nadeem, yes.
First of all, whenever you say biosimilar is not the copycat of the reference molecule. That's number one. Number two, when you create a biosimilar, once the patency goes off, you make a molecule which pharmacologically the outcome will be similar. And that's what is biosimilar, because it is not a copycat of the reference molecule. Remember that. So what the ranibizumab, whatever biosimilar comes out, so the pharmacological modulation, pharmacological pharmacokinetics and pharmaceutical outcomes are almost similar. That is how biosimilars are defined. And that is how most of the biosimilars which are in the market, they don't copycat the patent drug. They copycat the outcome and the pharmacological modulation, pharmacokinetics, and pharmaco outcomes. That is what the biosimilars is all about. Whatever it is, biosimilars has played a significant role in reducing the potential public health economic burden. And that is how it has worked in rheumatology, so many cancer medications, so many biologic drugs treating breast cancer, treating colonic cancer, so many out stuff. So this is already, but in ophthalmology, it has come now. And ranibizumab was the first drug biosimilar which has come out and given a widespread potential to do more biosimilar to reduce the public health fund so that the accessibility to care increases. That is why the aflibercept is coming now, then which is definitely got approved recently for 2 milligrams. So biosimilar is a potential drug to reduce the potential financial burden and the public health burden on a country. And that is how biosimilar works. Okay, and that is how it works. And biosimilar may play a potential role in many countries. And that is how it works. It depends on how the country works on the medical.
I think Dr. Nazim, this point already, take all the explanation. If there is any other extra, because we are also having a lot of time. Yeah, Dr. Rahoma, please. Dr. Rahoma,
Thank you
please.
so much. Thank you so much. Like, this is my first time here, so I'm not very familiar with the format, but the biosimilar in Pakistan, I'll just give you a narration of the Pakistan. In Pakistan, we do not have biosimilar at the moment, but this is something that is the talk of the town, that we would like to have something that is financially, less burden on the population and less monopoly to reduce the monopoly of the system. You're having the three important anti-VEGFs, so biosimilars will work and should work. But I think one thing that's very important, that all the research that is being produced and is being shown at the here with the even of the ranibizumab of the 206. I was just going through the research. It was between 212 to 216. All the research that was being presented. So I think it's very important that we present the latest research. And when we talk about the biosimilars, we look at the research and then compare with them. And these biosimilar, I think in future, it's very important that living in Asian population, we do these research on the Asian population and see how effective these biosimilar products will be in our society. Because whatever we present, whatever the research that is highlighted is usually of the Western population. So the day the biosimilar will be easily available, I'm sure that on the platform of MEOM, I think we can easily work on it and have this presentations on our data and then on our research. And I think, though I know, because biosimilar is something that we all are very fascinated and interested in happening in the future, it's just a comment. Thank you.
I think, Dr. Jeff, I want to have a little comment about it's available in India a long time. I think they start this one in 2015. And they are having an experience, and the biosimilar was started there as ranibizumab. So, and it was published there is many publication about this one. So now it's become everywhere, not only in India when they start. So, and now not only ranibizumab, there will be an aflibercept 2 milligram also available in the market. Also, it's available already, not it will be. Okay, I think if there is any, Doctor, in very fast, because we are
just in a nutshell, actually, what Dr. Nazim Al-Hussain has mentioned, the difference between the biosimilar, biosimilar is basically, it's not a generic drug that's to be taken home. Biosimilar is not a generic drug.
Yes. It is just a copy, but not in the similar. I mean, they are giving the same effect, the same result, everything. And there is some structurally some similarity, but not shouldn't be in the same way. There will be a modification, but give the same result. Okay. Is there any comment, Dr. Sifda?
Yes, what I want to say first, thank you sharing for this nice presentation about biosimilar and excellent work. In my country, in Azerbaijan, still we don't have any biosimilar. We are using Lucentis and Eylea and Vabysmo. Of course, Vabysmo, still now we don't have the biosimilar. But what I want to say, of course, what I want to say, first, we are retinal specialists. We need the patient safety. And sometimes we just start using for example, nowadays I am using Vabysmo, but after using Vabysmo for 3 or 4 times, I get some efficiency, and I want to change to other group. In this time, I need biosimilar, but in my country, we don't have biosimilar.
Sooner, maybe through you.
Yes, and and we can get, and biosimilar. One thing, biosimilar just can help reduce treatment cost. That's all. It's potentially.
I mean, if you are the end result, let's say in the other word, Dr. Sifda, biosimilar is similar drugs to this, as Dr. Muhammad and Dr. Nazim and Dr. Homa, everyone said, it is similar immunogenicity, efficacy of one drugs like ranibizumab. Now we are having one ranibizumab expensive, the other one is very less. That means you have a lot of people, they are not able to get this medication. Now it will be
correct.
And it will decrease the burden on the health service system. It will decrease the burden also on the patient, and give the chance for the people they are not able to get it to be easy get this medication, which is solve their problem. I mean, this is a very big important thing.
But we need some study about it. Ranibizumab and biosimilar. That's all.
No, there is nothing without a study. All he mentioned is a study. There is a study. There is publication. There is a lot. I mean, now we are more than 10 years about biosimilar, not only 1 year or something new. But maybe it become now, I mean, more, publicity and in everywhere, because now many countries start using. Before it was only started in some area, but now it's almost everywhere they are looking to use this one. I think
we also had some discussion with head of biosimilar study group with Ashish about it, and
he's the guy.
He is one of the guys that they are working on this. So we can move now to, I think we spent a lot of time on this, Dr. Muhammad Atif. Thank you, Dr. Muhammad. So we can go to our first speakers in the young ophthalmologists that we will have cases, and it will be interesting that we will have discussions. We'll be very fast, so we'll finish on time. The first speaker, I think, Dr. Aziz, who is the first one?
The first one is Dr. Atanas.
Okay, Dr. Atanas, please, the floor for you.
Thank you, everyone. I love the discussions, and we're going to switch gears and move to glaucoma. So I'm going to talk about the microinvasive glaucoma surgery, an overview, and I have no financial disclosures. So glaucoma is the leading cause of irreversible blindness worldwide. You know this, and traditional methods such as trabeculectomy or tube surgery are very effective, but carry risks for complications and have long recoveries. MIX, on the other side, is developed to be a safer, minimally invasive surgery, which could treat mild to moderate cases. And let's jump straight to the case. We have a 70-year-old patient with primary open-angle glaucoma. He's in a moderate stage. He is pseudophakic on both eyes, and he has progressive glaucoma, although he's on triple drop therapy. The visual acuity is 0.8 and 1.0, and the IOP is 14 and 13, and the Tmax is 15 and 14 on the right and the left eye, respectively. He's currently on dorzolamide, timolol 2 times daily, and latanoprostol, so 3 active agents. And if we look at the RNFL changes, we can see that on the first 2 pictures, he was stable, then he progressed, then we added the timolol and dorzolamide eye drops in addition, and then he was stable for a year, and then we see signs of progression. This was confirmed by visual fields, which I don't have, but we do have multimodal imaging with the ganglion cell analysis, and actually this pointed to be correlate. So what would you do in this case? Would you add an additional IOP lowering eye drops? Would you wait and observe, maybe control with OCT and visual field in 6 months and see how it goes? Would you treat with mix or microinvasive bleb forming surgery? Or would you treat with filtering surgery, for example, trabeculectomy, or with a tube?
Okay, do you want, to discuss, or you want to continue?
Sure, we can discuss here.
Okay, I think we need Dr. Barol here. Dr. Barol is a glaucoma consultant, and she can give us her insight of here.
Good evening. I think since the patient is already on 3 drugs, it's unlikely that just a mixed procedure is going to do wonders, because it works the very best when it's an early stage of disease and patient is like on a single drug, max 2 drugs. So probably what I would like to consider is an MIBS or a trabeculectomy. That's my thought. I'm not a fan of primary tubes, so the central 2 options, MIBS or trabeculectomy for me.
I completely agree.
Any other from our colleagues have any comment, please? Okay, so the only one available, glaucoma, Dr. Barol. So that's
perfect. I agree totally. Great discussion.
What you have done, Dr.
But maybe before I continue, I would ask you, why would you not add an additional eye drop?
Well, the surface is already compromised. Adding another drug is not going to lower the target pressures too much. So the 4th drug addition would not be as effective as the 2nd or the 3rd one. So as we go on adding more drugs, the efficacy of reaching a target intraocular pressure becomes more difficult. We can use combinations like prostaglandin with timolol and a combination of brimonidine with carbonic anhydrase inhibitors. 4 drugs, 2 bottles, 3 drops. But whatever it is, adding another drug after a certain number of drugs is not going to be as efficacious as surgery. So,
fantastic.
At the most, you're going to ruin the ocular surface and compromise the outcome of the surgery that you plan to do.
Exactly. And I think everyone should actually take this as one of the key points from my presentation. Adding additional drop is not always beneficial, and sometimes you have to intervene. So what we went for is we went for mixed surgery, although MIPS would be a great option as well. And I wanted to talk about it. So MIX is a group of surgical techniques that aim to lower the IOP in mild to moderate glaucoma. It uses microinvasive techniques with less tissue trauma. It has a high safety profile and a rapid recovery. When it comes to the post-op expected IOP lowering, I would say it's mild, maybe moderate. MIPS, for example, has a moderate effect, and trap and tubes have a very obvious IOP lowering effect. And this is why, if you look at the anterior chamber anatomy, actually what we're treating with MIX is the trabecular meshwork resistance. So it could be done with treating the angle directly through stenting or cutting, or it could be done through a supraciliary choroidal implant, while MIPS, on the other hand, gives you an outflow pathway, which is subconjunctively, and actually you get a bleb. This was also talked about in the latest EGS, European Glaucoma Society guidelines, where it says that MIX offer moderate IOP lowering, and it's used for mild to moderate glaucoma. And we actually observed a paradigm change in the treatment of glaucoma. Earlier, the classical way was to give eye drops and wait, prescribe more eye drops, and eventually go to surgery in the late stages of glaucoma. And now the new model is early intervention, the so-called interventional glaucoma. We actually have in the guideline that SLT could be the first line of treatment, then we prescribe eye drops, and then we intervene with surgery like MIPS or MIX early. Not all MIX are the same. So we have the stenting with, for example, the eye stent or the hydrus. And there are some studies which are actually more with data from more than 5 years. For example, the Horizon study for the hydrus, which actually show a great effect. We have the excision techniques. This could be done with Gehuctal blade, trabeculotomy, gonioscopy-assisted transluminal trabeculotomy, Helios laser trabeculostomy, or the VLAs, the femtosecond laser system. And this is actually what we did with our patient. We did an internal viscocanaloplasty with goniotomy of 180 degrees. So what we actually do first is we do the inferior dilation of the SWAM canal, and then the superior 180 degrees, and then we do the inferior goniotomy. This is how it looks like. You can also do it with a Kahook blade. There are studies that actually show that if you do over 180 degrees of goniotomy, actually you get no benefit, you get a plateau. So this is why in our clinic we do 180. Some information about the Kahook blade. It's a titanium blade with sharp edges that could be used to cut the trabecular meshwork and reduce the resistance. You can also use a Prolene suture, the so-called GATT technique, or you could use excimer laser, which actually opens up 10 channels. This is called the Helios system, in order to increase outflow through the trabecular meshwork, or the femtosecond assisted goniotomy with VLAs. Last but not least, you can dilate the Schlemm canal without cutting it, and this is the less invasive mix technique. It could be done with the Omni system or with the apinternal canaloplasty iTrack. Of course, there are studies from more than 12 years, which actually show us great results, but only in mild to moderate cases. The supraciliary implants, we use the iStar Miniject system, where we implant the stent in the supraciliary space just above the ciliary body. And there are some meta-analysis from the STAR trials 1, 2, and 3 that actually show long-term data. We actually observe a spike effect around the 21st day to the first month, where actually we have a closing of the cleft around the Miniject, and then we get a IOP increase, but then this is only temporary. We can also do up-internal ablation of the ciliary body, which is called the ECP, or endocyclic photocoagulation, and this could be combined with cataract surgery. Actually, all of the mix, and this is the great benefit, could be combined with cataract surgery or be used.
We are beyond the time, Doctor. If you can conclude, please. Okay.
3 take-home messages. Mix are safe and effective, but should be used in mild to moderate glaucoma. They are personalized and could be combined with cataract surgery. And mix is taking an increasing role in glaucoma surgery nowadays. Thank you so much.
Thank you very much. I want to highlight a very nice and excellent presentation. I want a comment from Dr. Barol within 1 minute, because we need only to stick to the time, only 5-minute presentation, and then 5 minutes for discussions. Okay, Dr. Barol, if you want to say something.
So,
okay.
Wonderfully presented, as already mentioned. What was the post-operative outcome of your patient, and how long did you follow up, and is his structural and functional testing stable as you wanted it to be?
Yes, so we followed up the patient for 2 years. I couldn't get the pictures, but actually IOP was stable. We thought about reducing the IOP medications, but we ended up not doing this, and the IOP was stable about the mid-teens, so never went above 15, and the patient did not progress.
3 drugs?
The IOP was around 40, 15, and did not progress.
That's what I said, with the 3 medications that the patient was putting?
Yes, we left the medication, the 3 medications.
Yes. So what was the advantage of doing a mix? The mix didn't really contribute much to the outcome. You're using the same number of medications, not even a reduction with a single drug. So do you think that the procedure was a success? Because we don't have a corroborative proof to see whether it was a success. The only thing is that the number of drugs is staying the same. So evidence built. I mean, you talked about a lot of other generic MIGs, but you should have focused more on your outcome. So that's my comment. But otherwise, beautifully presented. Thank you.
Thank you.
Thank you very much. Just I want to highlight that this the barcode. Please scan this barcode. This is for attendees, and then evaluate and give an evaluation for attendance. It is just we are enjoying all the information. This is just a fun and also for enjoyment, and see how the people, and there will be an evaluation by expert also. Okay, so if everyone is scanned, so we can stop, or everyone okay? So we'll give another 10 seconds. Then we move to the second speakers.
Yeah. Oh.
Okay, we can stop Abdullah scanning. Okay, and we can get the result later on at the end of the this meeting. Also, we ask our expert just to evaluate and give the evaluation and send to me in personal, please, not in the group. Thank you. So now second one, Dr. Aziz.
Next, we have Dr. Ganboler from Mongolia. Dr. Ganboler, please.
Do you hear me now?
Yes, we can hear you.
Ah, okay.
Can you share? Okay, yes.
Okay.
We can see you
Hello,
very well.
everyone.
Can you go ahead? Yeah. Hello.
I'm Kamodar Turbat from Mongolia, and I'm first year residency. And I would like to present the rare and challenging case, not your typical vasculitis, and aggressive immunosuppression required.
Dr. Ganboler, can you turn on your camera, please?
No problem. It's okay. You can continue.
Yep. Thank you.
Okay. We have a 53-year-old female and coming to our clinic with the sudden progressive visual decline and floaters in both eyes. And she has no past ocular history and past medical history. And our first examination, and the right eye visual acuity was 20/200 and left eye was 20/40, and anterior segment was normal, and we have some vitreous haze. On the fundus image, we have this, it's a right eye fundus color photo, and we can see it's due to vitreous haze, we see this blurry imaging. But we can see the hard exudates and some fibrovascular proliferation, and around the optic disc, we can see the neovascularization. On the left eye, we can see more like exudates and macular star exudates and some neovascularization around optic disc and optic disc edema. And some around the arterioles bifurcation, we can see there's a blood heme and macroaneurysms and arterioles sheeting. On the B scan, both eye we have vitreous opacity and some hyperreflective on the left eye around the optic disc and some exudates, and on the right eye we can see there's a fibrovascular proliferation as well. And fundus fluorescence angiography is very important to diagnose vasculitis. So here's we can see on the right eye, there's more, we can clearly see the neovascularization around the optic disc and the fibrovascular proliferation and arterial sheeting and overall like hyperfluorescence wave. And there's a bow imaging on the arterioles bifurcation. We can see a few macroaneurysms. In OCT2, we can see there's extensive exudates in outer nuclear layer and some optic disc edema in both eyes. And on the right eye, we can see there's a fibrovascular proliferations as well. Based on that ocular findings, with our primary diagnosis was bilateral severe occlusive retinal vasculitis with the narrow retinitis. And we did some laboratory testings as well, and all were negative, that inflammations and systemic causes were excluded. And given ocular findings and absence of systemic disease, we put our clinical diagnosis is bilateral idiopathic retinal vasculitis and narrow retinitis, stage 3 to 4. And we also did the HLA-AB in low resolution. Our patient has HLA-B 51 phenotype. Because differentiate Behçet's disease, we did the HLA phenotypes. And our management was Dr. Anar Sahal initiated the intensive treatment immediately, high-dose methylprednisolone intravenous, and continuing with the oral anti-inflammatory steroids and anti-VEGF and local steroid and immune-sparing agents. And after that treatments, our eye visual acuity on the right eye 20/40 and the left eye 20/25, and inflammation reduced after aggressive medical management. And our Dr. Anar Sahan and the Engsos, they did the panretinal photocoagulation 8 times. It's 8 sessions, once a week or once in a 2 week. After that, both eyes visual acuity is 20/20 and ocular inflammation had resolved. And we did systemic complication control with other specialists. And here's the right eye pre-treatment pictures and after first PRP and 6 months after taking MMF. All inflammation reduced, resolved, and the vitreous haze is cleared. And we instead of heavy PRP, dense heavy PRP, we did the after active vasculitis repeated few PRP, occasionally at the time of new vessel grown, only new vessel grown areas. Direct treatment of neovascular front into vitreous were beneficial.
Only 1 minute to finish, please.
And idiopathic retinal vasculitis, aneurysms, and narrow retinitis, it's a rare condition and common in young and female patients. It has diagnostic criteria, major triad and minor triad, and it has staging systems 1 to 5. And we have there's no standard treatment protocol due to it's rare. We have immunosuppression, systemic, and photocoagulations as well. In our cases and the other cases where we did the follow-up in 8 months now, and both eyes 20/20 without any worsening. And our cases highlights was it's bilateral involvement and arterioles, predominance, macroaneurysms, and our classic 3 major and minor signs were completely presented. And it's well
Please, we need
tolerated.
to conclude. Doctors, you are behind the time. Only,
Okay.
yeah, let's conclude.
And although no standard protocol exists, we did the repeated PRP with early systemic and local aggressive therapy for acute control rather than single day sessions. So we can achieve excellent outcomes even in advanced Irvine syndrome. And we may represent it's actually HLA-B 51 is associated with the same pathogenic pathway with Behçet's vasculitis, but without any systemic features. Thank you.
Okay, thank you very much. Is there anyone want to comment on Dr. Gamboler presentation and case? Dr. Awadallah?
Thank you for the presentation. HLA-B51 is strongly associated with Behçet's disease. So the interesting thing that it's an isolated ocular severe vasculitis without marked systemic manifestations. I guess is this not the typical presentation of Behçet's disease? This is my comment.
Okay, any others from our colleagues in
Can I?
Dr. Sevdayas, please.
So thank you for this excellent presentation. And its main things here in Irwan syndrome, I found the positively particularly intriguing given the overlap in retinal vasculitis pattern. Do you think this case represents true Irwan syndrome, or could it be part and ocular limited Behçet disease spectrum without systemic manifestation? I just have a question.
Okay, thank you for the question. And I think we are just due to it's a rare, so we just I think maybe suspected that just ocular limited vasculitis phenotype it can be, I think.
I think
okay.
I think many a times you will see there may be a genetic overlap between two different diseases.
Yeah, it can be
Maybe,
genetic.
yes.
Yeah.
So
actually,
Dr. Sevda, your voice is not very clear.
Congratulations. This is actually a very interesting case to find particularly important in Irwan syndrome. Also about PRP and retinal for ischemic retina, and do the for peripheral ischemia doing the fluorescein angiography, and how extensive was a non-perfusion on wide field angiography. Actually very good. Congratulations.
Okay, thank you very much for all.
I think
because the main reason, main reason is here. Treatment of peripheral retinal ischemia, main goal here. It's excellent case. Very rarely and excellent case.
I think you should follow up for this patient for a longer time. He may develop systemic symptoms and signs of Behçet's disease. Sometimes Behçet starts with the eye, and after some time, it presents with the systemic. So I would recommend that you follow up this patient in particular for a longer period of time. Also, it can relapses in the eye.
Dr. Homa?
Yeah, I just wanted to add it's a beautiful presentation. If it was in my part of the world, we'll be looking at tuberculosis as the first thing because having a bilateral. But I just wanted to ask that having the protocol of treatment, like starting with the steroids and then going towards the anti-VEGFs and then to the like posterior subtenon. When was the pan-retinal photocoagulation added to all this? And when did the patient actually was considered as stable and free of uveitis? What was the full protocol time period starting from the disease identification till the end? What protocol was steroids to this, and how many months or when was the next regime added to the first one?
Dr. Jen Bowler, the question for you. You are mute. We cannot hear you if you are talking. Okay, we can move to the next speaker because I think we are not able to hear the reply from Dr. Jan Bowler, I think, Dr. Homa. Okay, the third speaker, please. We need to stick to the time, please. We are taking more time than it should be. Only 5-minute presentation and then 5-minute discussion. Okay. Now, Dr. Aziz.
Dr. Kamal Tekin from Turkey.
Okay, Dr. Kamal, please
Yeah.
go ahead.
Good evening, everyone. And before starting, I would like to thank MEOM Academy for this excellent organization and for the opportunity to present my interesting case at this scientific webinar. Today, I will mention about the case showing retinal pulsation. My case was a very old man who was 86 years old, and he admitted with bilateral decreased vision. He was suffering from diabetes and hypertension that was very uncontrolled. And according to patient history, we have learned that the patient had undergone multiple anti-VEGF injections in other clinical centers before. His visual acuity was very low, only counting fingers. Sorry?
Dr. Sefda, if you don't mind, can you make mute? Yeah, thank you.
Yeah, his visual acuity was very low, only counting fingers at 1 meter. IOPs were within normal limits, but the biomicroscopy demonstrated degenerated IOL in both eyes. And because of this degenerated IOL, we could not capture fundus image very clearly. But anyway, when we look at the fundus, there was a typical myopic alterations, including tilted disc, peripapillary atrophy, and widespread macular atrophy in both eyes. In addition to these myopic alterations, there was dilated macular vasculatures in both eyes, as indicated by arrows. This is the fluorescein angiography that more clearly demonstrates these dilated macular vessels. And in the late phase of angiogram, there was window defect hyperfluorescence. This is the B scan of the patients that includes some artifacts because of patient low cooperations as well as degenerated IOL. But the correlate was very thin in both eyes as expected in myopic eyes, as well as there was macular atrophy in the right eye and juxtafoveal scar formation in the left eye. Interestingly, as seen in the bottom image, the macular vasculature was also visible in the B scan. So far, these findings were not extraordinary, but the rare aspect of the patient start with OCT video record. This is the OCT video record. There is a prominent retinal pulsation related with subfoveal macular vasculature. When I firstly realized this pulsation, I was very excited, and I recorded this video by using my mobile phone. There was a nasal displacement, and now I'm showing another video. This is directly taken from the device, and please take attention the changes in the vessel of the subfoveal vasculature. There's a very prominent pulsation associated with there's a nasal displacement of macula. After seeing this pulsation, I decided to perform video ICG to evaluate whether these pulsations were also visible in the video ICG, but the patient didn't accept video ICG examination because of his uncontrolled hypertension and other systemic status. Anyway, I'm showing you ICG images of the patients that were taken in other clinical centers and approximately performed 6 months ago. As seen in the ICG image, the macular vasculature was clearly visible in both eyes. And comparing to right eye, the left eye had more vessels and their lumens were also wider. I'm telling that because this may explain why we could observe these pulsations only in the left eye and there was no pulsation in the right eye. I'm not completely sure about the diagnosis, but I thought that these pulsations in this myopic eye happened due to presence of posterior vortex vein. As known, in healthy eyes, there are usually 4 vortex veins that drain the choroidal blood flow, and their exits are typically located at equator as landmarks. However, abnormal location of vortex vein may occur associated with several ocular and systemic disease, for example, oculocutaneous albinism or trisomy 13. But pathological myopia is another ocular condition which is related with posterior vortex vein, and it was shown that pathological myopic eyes could have posterior vortex veins up to 26%, and their presence in these eyes may be associated with posterior staphyloma, choroidal neovascularization, and macular atrophy or scar formation. However, the pulsation of posterior vortex vein is a very rare clinical entity, and in the literature, there are only a few cases. All of them have pachychoroid, and these pulsations were shown by video ICG. This is an example, and please take attention to superior fovea. In the video ICG, there is a very low amplitude pulsation, and it was suggested that this pulsation in the pachychoroid eyes may be related with congestion of the pachychoroid vessels and vortex vein, but the amplitude, the morphology, and the etiopathogenesis is different in our case. Because of that, there may be other explanation in our case about the presence of these pulsations. As a conclusion, although pulsation of posterior vortex vein on ICG has been shown before, this was the first report demonstrating spontaneous prominent pulsation during OCT in an eye with pathological myopia. This brings me end of my presentation, and I'm open for your questions and also for your valuable comments. Thank you for your time and attention.
Thank you very much. Thank you, Dr. Kamal. Very nice, and also near to the optimal time. If there is any comments from our colleagues, Dr. Muhammad. So I asked also before we go to the comment, this is the if anyone to scan and give the evaluation, please. Okay. Dr. Muhammad.
Nice presentation, Doctor. Pulsations of retinal vessels are sometimes physiological pulsations, but exaggerated pulsations sometimes you see with certain conditions, especially with the cardiac. The vessel usually pulsates with the cardiac cycle. So, for example, if you have a cardiac disease like aortic regurg, you can have exaggerated pulsations of these vessels, especially if you have a thin retina and the choroid is showing through this retina. So you get those exaggerated pulsations. So I guess one of the workups should be to send him to the cardiologist, could be something like that exaggerates the seen physiological pulsation. But physiological pulsations, we can see, for example, cases of disc edema, papilledema. And I think there is, if I'm not mistaken, there is some machines in the past that used to measure these pulsations. These are mostly of academic interest rather than clinical thing. Anyway, thank you for your presentation.
Is there any comment fast? Any fast comment we have?
Sorry, may I respond, Mohammed?
Yeah, please, very fast, please. Yeah.
I completely agree that, and for this reason, I consulted the patient, both neurology and cardiology departments, and it was very tragic that after a few days later of the ocular examination, the patient died because of the ruptured aortic aneurysm. It may be incidental. I am not sure because the patient had very old and he had uncontrolled hypertension. There may be relationship. I'm not sure, but the patient died just a few days later because of aortic rupture.
This is always exaggerated pulsations of vessels. It can come from the cardiac cycle. And if the cardiac cycle is exaggerated, like in aortic regurg, or of course, aortic aneurysm causes aortic regurg. So because the pressure between the systolic and diastolic is increasing, so it gives a bigger pulse. Anyway, thank you for the presentation. It's
Thank you
interesting.
very much. Thank you. We can, Abdullah, go to next presenters. Dr. Aziz, if you want.
Yeah.
Dr. Muhammad.
Next is Dr. Mohammad Reda from Egypt. Dr. Reda.
Okay, sir, I'm sharing my screen. Sorry, sir, just 1 minute. Okay, sir. Good evening, everyone. I'm Mohammad Reda, Assistant Lecturer of Ophthalmology of Cornea Unit at Memorial Institute Kids Eye Center. I will be presenting today compressing suture technique in pediatric acute corneal eye drops. I will show today two different cases of compressing suture in pediatric acute corneal eye drops treated with two different techniques of compressing suture and what about the difference in results between it. My first case is a female patient, 7 years old child with sudden onset of pain, redness, tearing, and photophobia, and sudden onset of decreased vision in the left eye for 5 days ago, with positive family history of VKC and keratoconus. By examinations, right eye best corrected is 612, and by slit lamp examination showing photostriae, flesh ring, and fundus was normal. When the left eye is visual active with hand motion, and slit lamp showing marked corneal edema with stromal swelling, with large central and paracentral eye drops area, and basement membrane break was visible with conjunctival injection and tearing, and fundus to me not visible due to edema. So what is my mindset differential diagnosis for corneal eye drops in general is that every corneal bulge equal eye drops. I have another option like staphyloma, anterior staphyloma. Another question to me, every corneal eye drops equal keratoconus. I have another pathologies like corneal pathologies or other ocular pathologies. Corneal pathologies like keratoconus, keratoglobus, tearing, marginal degeneration, or secondary to refractive surgery, or other ocular pathologies like infantile glaucoma or forceps-assisted liver. And the third question to me in my mind, if every corneal stromal haze or whitening mean eye drops or maybe infection, it's not necessary that corneal eye drops present in a clear image like that. We can have a moderate case or mild case, and I can misdiagnose for infection. So the complete history must be completed for diagnosis of corneal eye drops. So I asked in this patient in right eye pentacam, which showed the keratoconus, and in left eye anterior segment OCT, which showing basement break and stromal edema. So my diagnosis is acute corneal eye drops in a pediatric keratoconus. My clues for my diagnosis in this case that it's acute onset of normal risk group like VKC. Basement membrane rupture was visible to me. Stromal edema with this not infiltrate or infection associated with eye rubbing and allergy. And the other eye is keratoconus by pentacam and anterior segment OCT showing the break of basement and stromal edema. So what is the plan of management in such a case? Should I start conservative treatment and for how long? Should I do compressing suture in the first presentation? Or when I will inject air or not? Keratoplasty, when I will have to do keratoplasty in a pediatric age group like that? So in this case, I started with initial conservative treatment like hypertonic solution, cycloplegic drops, topical and systemic anti-allergic treatment for VKC, and topical IOP lowering agent. But unfortunately, symptoms persist without any improvement after 5 days. Why rapid intervention, especially in pediatric age groups in acute corneal eye drops? What is the pediatric considerations? I am afraid from what? Prolonged edema or stromal edema could cause a strong opacity or dense corneal opacity like that, which can affect the vision for the child and can causing amblyopia, the fear of amblyopia in pediatric age group. Also, I can go for keratoplasty for this opacity, which is high incidence of failure rate in pediatric age group. So when if I do a something like compressing suture, I have a better result, which published in a lot of papers. And this is published in 2026, last paper published that conservative treatment alone have a risk of new vascularization risk and longer period for resolution when air alone could be resolved for 20 days, when compressing suture for 4 weeks. So I to take a decision to do a compressing suture with air injection. So I started a small puncture, stromal puncture to milking the stromal edema. And then I started a compressing suture perpendicular on the basement membrane to get it near to each others. it should be tight stitches, 6 to 8 stitches is taken, simple interrupted, and very tight to compressing the cornea. I will show the end of the video for the time of the presentation. So for this case, and what about the result? 3 days post-operative, signs of reduced stromal edema and visual acuity improved from hand motion to counting finger 1 meter. After 1 month post-operative, from counting finger to 360. And I don't forget the other eye. I did a cross-linking for the other eye. And after 7 weeks post-op of removing the stitches, I have a scar central, and the vision improved to 636 with psychoplegic once daily to overcome the central opacity, which was a good journey for this child. And the real challenge is the smile of the child in pediatric cornea. So I will show my second case rapidly for time. This is the same, another case for corneal eye drops, diagnosed as corneal eye drops with same approach.
Dr. Muhammad, because of sake of the time, there will be a discussion. I don't know, it will be.
Okay, sir. Okay, sir.
Okay. I think I need Dr. Hiba and Dr. Ahmed Ghunaim, so they can discuss the case.
Okay, sir.
And comment.
Okay.
Thank you, Dr. Muhammad, for this very nice presentation and interesting cases. Actually, corneal opacity and corneal problems are very challenging in a pediatric age group because you are in two minds whether to go for keratoplasty, which has a very lower post-operative or bad prognosis in most of the pediatric population. And so I find the compressing sutures is amazing solution for such cases. I congratulate you for the end results about 636, because after keratoplasty we don't expect more improvement of the visual acuity in those cases. So thank you for your case.
Thank you, sir. Thank you.
Dr. Ahmed Ghunaim. Dr. Ahmed. Dr. Ahmed موجود? Any others of our colleagues? Dr. Barrel, if you have any comment from your side?
No, I just related to the compression sutures that we use for over-filtering blebs. So beautiful results, and yeah, both the techniques were nice. Yeah.
Thank
but
you, sir.
For me, this is the first time I hear about that. There is something like it's called compressive suture. To be honest, we are not familiar with this. So
it's not very popular, Dr. Al-Amri, but it's an amazing solution in keratoconus. We had many cases in the Memorial Institute Kids Eye Hospital with a very good results, and we are to publish those cases soon, inshallah.
Okay, these cases usually, I mean, it's part of the treatment of keratoconus only, or treatment of acute eye drops of the cornea. I mean, what is the rationale or something behind this idea?
The compressing suture, sir, it's for acute onset of corneal eye drops. It's a treatment of the acute onset. When
Okay,
it's
what is the mechanism of does the doing this, what the effect?
When we do a milking for stromal edema, decrease the corneal edema, and then did a corneal compressing suture to get the two descent edges, which is broken, which is the pathology of acute eye drops. We get it together near to each other with tamponade by air, intracameral air injection, which getting more good effect on the cornea. When we get two descent together to each other again, and air injection for tamponade with to get the two edges near to each other, like that, something like that.
I mean, the problem here is the endothelium
Dr.
of the cornea.
It's like the cornea is like a sponge. So you press the sponge with the compression sutures from above and from air below, so it gets squeezed in and the fluid gets out.
So to approximate the two edges of the break, and you get rid of the accumulated water or fluid in the cornea, and so you promote healing. Another idea by the pediatric consultants in the hospital is to do sutures like the PKP sutures to avoid the sutures to be central and to aggravate the central opacity in those cases. And so that's, again, it's a better idea, I think, in those cases.
Anyway, thank you, Dr. Muhammad. Sorry that we interrupted
Thank you,
because
Doctor.
for me it's very interesting.
Thank you, sir.
I want to know. I hear about all the others, but this one for me it's something new, really. Thank you very
sir.
much for the case.
Thank you, sir.
I think already they put your barcode here for evaluation. So we can go to the next and the last, but not the least, Dr. Aziz.
Yeah, the last presenter of our webinar is Dr. Nilesh Kumar from India. So over to you, Dr. Nilesh.
Thank you, Dr. Aziz, for giving me this opportunity, and thank you, MEOM, for having me. So I'm just going to share my screen. Just a second. Is it visible?
Yes, please.
Yeah. So I'm going to talk on managing chronic DMD with ear pneumatopexy. And I'm Dr. Nilesh Kumar. I'm Secretary of UC and currently Consultant Director at Madhvi Netralaya, ARA. These are my financial disclosures. None are contradicting with today's talk. So what is a Descemet membrane detachment? It's just a physical separation between corneal endothelium and Descemet membrane complex from the posterior corneal stroma, which leads to the functional loss of endothelial pump mechanism. And with that, there is a rapid infusion of fluid that comes into cornea, and it causes diffuse, most of the cases, diffuse stromal hydration and microcystic edema that further goes on and becomes microcystic edema as well. The rate has come down with modern phacoemulsification system, but still, if you evaluate it very minutely, the subclinical microtears may be present up to 47% cases in multiple studies that were done using ASOCT. Most common is iatrogenic because of too much of phacoprobe going in and out, and most if the surgery is complicated, like doing trab, and nowadays with MIGS, the hook or any instrument such like that, it can tear the descements from that area and cause DMD. Most of the cause is because of dull surgical blade that is there, and it can also happen in advanced age. The biophysical principle of pneumatic tamponade is what was being just discussed by Parul ma'am. What she said is that you give buoyancy, and that hydrostatic pressure, it reduces, it creates a tension, and then the pump mechanism again starts to work. So we have to keep full AC during that tamponade. Most commonly is sterile air, because on table, if the adherence is achieved, then it is not like no further intervention is required. So most of the cases here with sterile air, but there can be use of SF6 or perfluorochlorine, that is C3F8, but those have to be in non-expansile concentration and little tedious to actually mix those. So coming to my case, it was a 80-year-old male patient who underwent surgery, left eye, and there was a immediate poor post-operative vision, and no significant systemic illness. It was left eye, sorry for the typo. The right eye was actually phakic NS1 with 6/12 vision. The left eye, the patient was having hand movement with microcystic edema and no anterior chamber details. As you can see, nothing was visible. Slight hint of membrane was found on slit. I couldn't take that image because the visibility was not that good. The fundus had no view. On ASOCT, what I could see was from limbus to limbus, complete detachment was there, and there were also like signs of chronic detachment with taut Descemet membrane at few places. So then we took the patient to OT. And this is the side port incision that is made, and this is, you see it, I'm not entering the chamber fully, it is just going to the area of hydration, so that if there is any fluid in that space, that potential space, it drains out. So multiple stab incision like that are made, and then now I enter the AC. And now the first incision that I make, I think that I went into the AC, but you see the second incision that I made, there are 2 air bubbles right now. So I went into a wrong plane and actually enhanced that DMD. So again, I drained the air out, put that waited for a few minutes, but I saw that there is no improvement in the visibility. So again, I was going into wrong plane. There were multiple planes in this because it was a large undulated DMD, so completely collapsed the AC. Again injected, again there was in wrong plane. So what I did there, because of use of too much of paracaine and viscoelastic, the entire epithelium was loose. So to improve visibility, what I did was to debride the entire epithelium. With that, the visibility improved a little bit, and then after this, I again collapsed the entire AC so that I could find right plane again, and then re-injected air into that, and with that, put one drop of lubricating drop. Again, I used a paracentesis. That this is over the previous main incision, so that I don't induce too much of astigmatism. Drained everything, and now you will see that there is a little bit of fluid that is oozing from that paracentesis made from my left hand. And with that, I thought that it is improving, so I closed the case, waited for, I finished another case on another table. It took me 10 minutes, and after 10 minutes when I came, I saw that the cornea was again, the visibility was there. So with this, I re-inflated that air bubble so that the tamponade is maintained for a little more than 1.5 hours. The patient was kept into supine position at the OT table for the entire duration. I just removed the speculum after this. Just saw that everything is there, AC is not collapsing, so that it doesn't get exaggerated. And after this, I next day, this is the enhancement that was there, and the patient improved to 612, and now at 1 month of follow-up, he is improving to 6.9. With this, I thank again for the opportunity. Thank you so much.
Thank you very much for this excellent case presentation. Is there any comment from any of our experts here available?
I think what I liked about this case was two very valid points that Dr. Nilesh made. First is that if it's a chronic DMD, when we do an ASOCT, we need to look for whether the descendant membrane is taut or is it dynamically moving. And second, to recognize the fact that there can be non-planar DMD. So there can be multiple planes, and we need to recognize and try to find the correct plane so that the issue is properly addressed. So just putting in air and getting out is not going to solve the issue. Finding the correct plane is the key to a successful outcome. So those 2 points, I think, were beautifully highlighted, and really appreciate the outcome and the effort that you've taken to tease out the fluid.
Do you think, Dr. Barrel or Dr. Anish, that if you go back a little bit behind, I mean, not in the cornea, I mean, through the sclera and go to the anterior chamber, it will be more easier?
No,
I agree. Yeah, ma'am, please.
The problem is in the cornea, so going to sclera is not going to address the issue. If it was chronic, he could have used also used a certain level of compression suture to tease it out had it become more chronic. So
I feel that if you are going through and then you are just increasing the cement membrane detachment more, if you go 3 times, 4 times in the same, and you are in the cornea. But if you go a little bit back, I mean, maybe you will not go through the cement. You will go directly to the anterior chamber, then you can inflate it, and maybe then it will be easier. I don't know. It came to me like this. I don't know. I never exposed to these things, but I'm telling in this way.
I think that approach has not been tried, but that is a very good idea. I operate in an area where there are too many CAB patients, and I keep getting these DMDs. So I will definitely try to, like, if such a complex case comes, I'll try to go like 1 mm behind the cornea so that I enter into the AC through the anterior chamber, the angle, and then probably will have a easier outcome. That's a very good idea.
Anyway, it was a great meeting with many, different and varieties of cases in different subspecialty in ophthalmology. Very nice. I like the meeting. I'm all the times learning, really, and get more information. We are not, sometimes you are concentrating in one subspecialty and you are forgetting all the others. So it is a chance sometimes just to expose to another cases and learn from all of you. If there is any comment, Dr. Homa, Dr. Awadallah, Dr. Hiba, Dr. Aziz, I don't want to miss anyone, Dr. Sefda. So anyone of you want to say anything? Then I think we went to now we want to select the winners from the attendees. Abdullah, we will start with attendees. If you have to make the polls, then maybe for the our speakers, if every one of our experts send me all the result of the 5 speakers, so then we can calculate, or otherwise we will announce it in the next meeting. Abdullah, can you do the polls for the attendees?
Excuse me, Dr. Mohammed.
Yeah.
Actually, I vote only for Dr. Nilesh. I couldn't vote for anyone because I have some internet connection before.
No problem. So we will use only the other
Just share
colleagues.
me the QR. Yes.
The other colleagues. We are going to use the other colleagues' evaluation. No problem.
Yes, or you can send me the QR, or our presenter again
No
can
problem.
share with us.
Later on, I will try to talk with you
Okay.
in our private.
Okay.
Okay, Abdullah, you are ready? So we need to finish.
The first speaker?
No. I'm talking that you need to select from the attendees, the winner of attendees. Forget the speakers. Did you make the attendees?
No, I was preparing the evaluation.
Okay, for attendees, you make the polls or not? Abdullah?
Yes.
Ready or not?
Not ready.
You will take time for the next
No,
time
not.
we can.
Next time.
Okay, so we will select only from this group they attend today 3 winners to have a free registration in MEOM 8 MEOM coming in October 30th and 1st till 1st of November this year. For our speakers, also we'll collect the result from all our colleagues, and we will send or announce the result in the next webinar. So we need everyone to be with us next time, inshallah. Any comment, Dr. Nadeem, or anyone of our colleagues here? Dr. Muhammad Awadallah?
Thank you, Dr. Muhammad, for a very nice Zoom meeting with a lot of interesting cases in all
Really?
subspecialties. This is really encouraging that we are now follow other subspecialties as well.
Yeah, well, there is a lot. I mean, there is all our subspecialty available. We have pediatric, we have glaucoma, VR, and cataract refractive. So it's very nice that we learn and we get new cases. And also next meeting it will be. Yes.
I would like to take the opportunity to thank all the speakers, Dr. Atanas, Dr. Nilesh, Dr. Ganbolar, Dr. Kamal, Dr. Reda, and especially their participating young ophthalmology societies for nominating them. And I would like to invite all of the attendees and the societies that we are having our next MEOM conference in the end of October, and we would be very happy if all of you join us in Dubai this year. We had a very great conference last year, and we are hoping for an even better conference this year too. So thank you very much, and hope to see you in the next webinar and in Dubai, inshallah.
Also, I want to add, Dr. Aziz, on your words that this year we will have the first day. It will be peculiar for a young ophthalmologist. I mean,
exactly.
And this is a chance for everyone who want to participate. And also, we are extending the for application for abstract and for everything abstract submission till the end of June. So anyone who is willing to attend and participate. And by the way, who is the winner today is going to win today from the speaker. He will be with us a speaker in the webinar, in the MEOM, and he will be a free registration. If there is any comment, Dr. Hiba, Dr. Homa, thank you very much. Also, we are happy that you are with us. Dr. Hiba, Dr. Nazim,
Yeah.
anything to say before we close?
Thank you, Dr. Al-Amri, for a very nice event and the presentations from all the young ophthalmologists. And I wish to have more and more meetings like this to encourage more and more young ophthalmologists to share in the Middle East Academy. And I thank Dr. Aziz Jan Bashir for his effort with the young ophthalmologists. Thank you so much.
Thank you.
Anyone from the speakers, you want to say anything? I mean, we are saying young, but you know, you are very expert people and you are doing
Beyond.
great job than, yeah, beyond, but you know, the age only. But for me, as I am, you know, I am younger than you all.
I wish I still be young.
I am younger, so, Doctor, so I am 27
I am
and a half.
young already.
Thank you very much. It was very nice. All of you done a great job. Really a very good and excellent presentation, excellent message, and it's very nice presentation and cases. Thank you for all of you.
Thank you very much, everyone.
In MEOM, see you in the next webinar meeting.
Okay.
So good night for all of you.
Bye.
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 Yeah. Bye. Assalamu
Salam.
Good night, everyone. Thank you. Thank you so much, Dr. Aziz.
alaikum. Thank you, Doctor.
Thank you, Dr. Aziz.
Welcome,
Bye.
Nilesh.
Bye.
Sevda, thank you very much.
Thank you very much.
to
What
go
you
to
are
sleep,
doing
I
for
know.
young after what?
You need to go to sleep after all this work, I
No,
know.
no, very appreciated. Thank you very much for this wonderful webinar. What you are doing for young ophthalmologists is truly remarkable and
We hope
highly appreciated.
we are learning from them. Actually, to be honest, they are giving a
Of
teaching us.
Of
Is a
course,
great.
yes, correct.
Thank you,
so
Aziz.
much.
Really appreciate, Aziz. All the work is and the things goes to
Thank
you.
you, Aziz.
Thank you.
Dr. Aziz.
Thank you, Dr. Sevda.
Bye. Good night.
Bye-bye.
Salam.